This video is brought to you by MD Anderson Cancer Center at Cooper.
Hi everybody, I'm Glen Macnow of 94 WIP with our MD Anderson Cancer Center at Cooper doctor. And this week, this month, it is Dr. David Shersher. How are you, Doc?
It's a pleasure to be here.
It's a pleasure to meet you. We're going to talk some issues about lung cancer today and factors of that. So before we do that, tell us a little bit more about you. How did you get into the field of thoracic surgery?
Well, I love surgery. You know, I was always interested in surgery, and then I always kind of migrated towards oncology, to the oncology field. And then I thought, where's the best impact for me at this point? You know, 220,000 newly diagnosed lung cancers a year. Wow. The best impact is in lung. I mean, this is a major killer, and if we get it early, if we figure out programs to get patients in faster, to get them treated faster, earlier stage, that's going to be the biggest impact from a whole societal level. So that's really what brought me into thoracic oncology. And then there's a challenge of the surgical side of it.
All right, well, let's start with the diagnosis part of it. Let's just discuss kind of generally what lung cancer is and how you diagnose it.
Sure, so lung cancer is a cancer of the lung. You know, there are two different main types. About 85% are non-small cell lung cancer, and about 15% are small cell. They're much more rare, and you really wouldn't see a surgeon if you had small cell. You'd see more of the oncologist and the radiation oncologist. You know, these are by far the most common two types. There are other different types of cancer as well. The other thing is to diagnose it. So oftentimes these are diagnosed by imaging. So either a patient comes in with a cough, or they have a history that a physician or their primary care doctor thinks is concerning for a cancer. They come in, they get some sort of an X-ray or a CT scan, and then ultimately they find a nodule or a mass on that CT scan, and that really just alerts us. So.
All right, so we get, Dr. Shersher, we get letters and emails from our listeners asking questions of the doc. And let's start with this one, which I have smoked a pack of cigarettes a day for over 30 years, this person says. How does that increase my risk for lung cancer?
Sure. So in 2011, there was a major trial. It's a landmark trial, which actually is the equivalent of, you hear people getting mammographies for breast, colonoscopies for colon cancers. So in 2011, it was a game changer for lung, because there was a trial that looked at patients who were smoking 30 pack years. So that means 1 pack per day for 30 years. So you take your pack per day, multiply by the number of years, and that's what you got. So 30 pack years. If you smoke 30 pack years, you're considered eligible for this trial, which essentially means that you should get screened. Your risk of getting a lung cancer after smoking that many years is actually significantly high enough for your primary care physician or your physician team to be concerned enough to actually recommend getting a CT scan.
Getting a CT scan, so that's one of the first forms of diagnosis.
Correct.
That's the first thing you'll look at, okay. Beyond smoking, and I think we've all heard since we were kids, smoking is the thing that leads to lung cancer. What other factors are in there?
All right, so cigarettes, so everyone thinks that cigarettes, it's the nicotine that causes the problem. It's not. It's actually the smoke from the cigarettes. It's all the chemicals. So there are 4,000 different compounds in your cigarette that can all lead to this, this process that develops cancer. So cigarettes, absolutely. 85% of people that get lung cancer are smokers. The remainder are other things in the environment, like asbestos, radon, things that you hear in the news. There are other things too, like genetics. So we don't really understand exactly how genetics play into all this. We have a couple of different mutations that we have targeted therapies for. However, we don't really know how genetics plus those exposures lead to this process that eventually develops into lung cancer.
What about diet? Is diet a factor?
Probably, but we don't know. There's no direct exposure. But I'm sure that if you eat well and you are healthy, you probably have other healthy lifestyles too.
Somebody else just sent in the question about COPD, if there's any connection between that and lung cancer.
So from a statistical standpoint, there is. But most people that develop COPD were also smokers. So we're not sure if it's the smoking that caused, it's the chicken and egg argument, or is it COPD that causes some sort of a gene mutation that predisposes you to getting lung cancer. But there is a relationship. COPD, emphysema, and lung cancer are all sort of intertwined with one another, usually related to smoking.
So there's a relationship. What you don't know, what you can't say is it's a causal relationship.
Correct.
But there is a relationship between the two. All right. Someone sent in, I'm getting surgery in the next few weeks to have part of my left lobe removed. How is my life going to change after surgery? Will I still be able to lead an active lifestyle?
So the answer for the most part is yes. So nowadays, we have many different options for patients. So most of these tumors are being treated, like in our cancer center, we have a multidisciplinary team. We look at every patient from the standpoint of how do we get them to the same quality of life after surgery and after their treatment as they were before. Even better sometimes, because sometimes people develop pneumonias and things of that nature that actually really get them down before surgery. So minimally invasive surgery, for example, VATS, robotic surgery, really is small incisions. People leave the hospital after 3 days of staying in the hospital. By the time they come to our clinic a week later, they're actually pretty much recovered. I've had a patient run a half marathon after doing pneumonectomy, so 2 lobes on the left side. It's 50% of the lung function out. So
how long between the surgery and the marathon?
About 6 months.
That's great.
Yeah. So it was a half marathon, but the patient came in.
13 miles.
Well, that's a mere 13. I can't even run 5 miles, but that's. But again, it depends on who you have coming in, and the importance is you get a patient in to a multidisciplinary team. We provide care that is tailored to that particular patient so that we get them to their best after the treatment.
Okay, so along those lines, some of the people want to know what are the risks associated with surgery. Surgery is a big step. What are potentially some side effects people should be aware of?
Of the surgery itself?
Of the surgery itself.
So one of the things, so obviously this is not a appendix surgery or gallbladder surgery. This is a chest surgery. So even with minimally invasive techniques, it still requires a lot of, a team, right? So it's not just the surgeon, but it's the whole team, all the perioperative care. And some of the risks that we see people develop some complications could be, things related to their smoking history. You're at an increased risk of heart disease, stroke, all those things. So that means that the average patient that we get, the 70-year-old that we get that has, say, 2 stents in their heart, they're at an increased risk of developing a heart attack. So the key here is we learn about all those risk factors up front. We take care of them up front through a multidisciplinary team. We really lower the risk, and so we try to get people through a very quick program post-operatively to get them recovered. All
right, so options beyond surgery, what are there? If someone comes in and you diagnose that they have, obviously the degree, the severity is an issue, but they have some lung cancer, are there other options beyond surgery?
So there actually are, and again, this is the importance of being in a team. So every patient that we see in our team, and I'm sure is being seen at other cancer centers and as a team, they're discussed at our tumor board, and we determine whether or not they're even candidates for surgery. Some people are just too frail, or sometimes we decide that the tumor is just too advanced. And so if that's the case, we have other modalities. So one of those modalities is chemotherapy or immunologic therapies. Another modality is radiation therapy, and there are many different types. So the traditional radiation therapy that we hear about, someone comes in every single day to the radiation oncologist, they get blasted with some radiation therapy, and they're done. Nowadays, we actually tailor that even further. So there's something called essentially surgiless surgery, which is cyberknife therapy, or some people call it SBRT. So essentially it's a beam that's shot directly into the tumor itself, and it eradicates that tumor, which really has been shown to be exceptionally good at treating the tumor itself. But still, the standard of care today, if we can get someone to the operating room, is surgery, remove the tumor, and get them aggressively treated with other therapy if they need it, depending upon what the pathology shows.
There is surgery, as you just discussed, and I know now there is surgery done laparoscopically, surgery done with robots. What's the distinction between the two? Is there a time when one's preferable to the other?
So again, it's patient characteristics, and also has to do with the size of the tumor, the location of the tumor. Sometimes it's impossible to safely do minimally invasive surgery. It's too dangerous. But for the most part, in at least 60 or 70% of cases, especially of earlier stage lung cancers, sometimes even higher than that, we can do it by a technique called VATS, which is laparoscopic for the chest, video assisted, or by the robot, which essentially is a very similar technique, also minimally invasive. And the advantage of these two techniques is that we get people out of the hospital sooner. And really, 1 week after surgery, they're almost fully recovered.
Wow.
It's unbelievable.
That is
it really
big,
is.
and that is clearly very different from what it was in the past.
Yeah, and even the open surgeries nowadays have changed. When you are talking about open surgery 20 years ago, I mean, you're talking about essentially, maybe 2 weeks in the hospital, right? Nowadays, with these programs pretty much across the nation, we can do thoracic surgery, with a minimally invasive, even open incision, preserve a lot of the muscle fibers, and be able to even use the video scope to assist us, but to get people through and get them out of the hospital 5 days after surgery. They recovered 2 weeks later.
Now, you mentioned CyberKnife technology and how that's now being used. Are there any other treatments, any other therapies you see coming down the pike that you're looking forward to?
I think, and this is, again, area of research. So the key, I love operating, but it would be great that if we get to a point where nobody smokes anymore and I don't have to operate for lung cancer anymore. I mean, that would be great, right? So there are new technologies available that we're experimenting with now, and we're actually finding some success, and that's endobronchial technology. So you do essentially minimally invasive evaluations of the airway. You can sometimes do interventions like taking a little, a stick with a camera and putting it in the airway, and you can actually put in little markers or things of that nature. And I think in the future there are going to be ways for us to be able to take care of tumors with a combination of therapies that may not require a surgeon to resect your lung. But that's not here, and that's not today, but maybe 10 or 15 years from now.
And your advice to everybody now is?
Stop smoking.
Yeah.
One of the reasons why I went into this field is because there really was, at the time that I went in, there wasn't widespread adoption of the screening program. And so you see across the country there are clinics that are opening up, nodule clinics and this and that. It costs $99 to get a CT scan. So sometimes it's not your primary care doctor that's going to tell you, get a CT scan. Sometimes it's your wife or your husband or your child that's going to say, you know what, you've kind of been smoking for a long time. You really should, you should get screened, because that's what saves lives. It's not necessarily what I do or what the oncologists do. It's getting screened early. Sometimes it comes from the, from the individual and the primary care team. So if you smoke 30-pack years or more, if you fit the age profile, which is 55 and above, you are eligible for essentially a CT scan that's covered by your insurance, or out of pocket $99, and you can send them to a pulmonary nodules clinic like the one we have, and essentially we'll take care of the rest.
Very good, thank you. That's going to conclude our chat for the day, Dr. Shersher. Thank you so much for your time, for your expertise, answering all of our questions. We really do appreciate it. If you would like more information on the MD Anderson Cancer Cooper program, please visit cbsphilly.com/CooperDocs.
This video is brought to you by MD Anderson Cancer Center at Cooper.